Hi guys, my name is Susan Rohde. I am a senior manager here at Eide. I've been here 20 years and I specialize in professional coding. And myself and Rachel attended the 2022 AMA CPT Symposium, and we are excited to present some of the findings that we heard there. And I want to apologize right off the bat. My children brought home some germs from school that they kindly shared with me. So I apologize if I have to stop to cough or blow my nose. So thank you very much, and I'll pass it on over to Rachel.
Thanks, Susan, and thanks, Amy. So I'm a senior manager in the healthcare revenue cycle area at Eide, and I do specialize in charge master reviews. I do quite a few charge master reviews for both large and small organizations. So CPT codes are near and dear to my heart. And as Susan mentioned, we attended the virtual AMA CPT Symposium just a few weeks ago, actually, where we learned all about the new CPT coding changes that will be going into effect on January 1st. So with that, I will get started. I do want to mention that when it comes to these CPT code changes, we are going to be touching on each of the chapters within CPT where the changes occurred. We're going to be providing more of a high-level overview. We won't be able to get into the weeds of every single CPT code change that took place. So we highly encourage you to take this information and review these sections of the CPT manual themselves for more detail. As you go through the changes that took place this year, we also recommend including clinicians that these changes pertain to. So that would be the providers, the clinical personnel within those departments, along with the coding teams, your compliance department, practice managers, charge master coordinators, your revenue integrity specialists, patient financial services, all of those different areas as appropriate should be included in these discussions. And you definitely want to make sure that you update your charge master files, your charge master and your fee schedules, and include those new codes and those new changes, as well as any electronic medical record preference lists or charge capture, charging mechanisms that might be built within those systems electronically. If you're using any paper charge tickets, you'll want to update those as well. So those are just kind of some reminders there on those changes. So getting into the 2022 changes, there's 405 total changes, and I've outlined here what are the new codes. There's the number of deleted codes and revised codes. There's 41 new COVID-19 related codes, that we'll get into some of those. 26%, so about a quarter of the changes are related to new technology. So those are going to be those category 3 codes. Technology is ever new and changing, so they're accommodating for these category 3 codes more and more each year. There's continued expansion of the proprietary lab analyses, that PLA section, and those are those proprietary lab codes based on the actual like brand names or organizations for those lab testing. There's some telehealth and digital medicine changes. There's been some revisions to the care management section of CPT, as well as some new codes for principal care management. And they also issued some evaluation and management guidance clarifications that we're going to go through. All right, so here's some of the COVID-19 related guidance. So there's going to be some testing, some actual like lab testing, diagnostic code changes, some new codes and some revisions. And I'm going to outline these in more detail on our lab and pathology slides. And then there's some vaccine related codes and some revisions and changes there. And I've got a vaccine slide that we'll go into next on some of those details. And then there's been a series of CPT assistant special releases that have taken place regarding some of the lab testing and the vaccination codes that have been implemented. And I've got a link that I can share with you so you can go directly to some of those CPT assistants. And then we'll cover a little bit of Appendix Q, which is located within the CPT manual, but you can also get to that online as well. All right, so some of the new codes regarding vaccines and immunization. So we've got some new codes that they developed for the reporting of the actual COVID-19 vaccine products. So those products might be Pfizer, Moderna, Johnson & Johnson. I do have those approved actual products listed there. And so they've got the actual administration codes as well as codes that are going to be specific to whether it's the first dose, the second dose, or a booster. So this Appendix Q that I mentioned and I have the link there at the bottom of this slide. That Appendix Q is a great tool and resource to utilize. It's in your CPT manual as well as online, and you can find the actual CPT code for that particular product, and then the HCPCS code that's going to specify which dose the patient received, and you can code for those. Now, the establishment of some of these codes it's been ongoing since 2020, and basically since the start of the PHE. So some of these codes are not necessarily new. As of January 1st, we're already seeing them in utilization now, but that Appendix Q has been updated to reflect all of these codes. So it's a really handy tool. And then as of March 15th, 2021, the vaccination administration reimbursement rate is paid at $40 per dose. And that is going to remain in effect until the end of the PHE. And then again, here is that link for those AMA special releases, as well as for the Appendix Q. So you can get all of that information regarding these vaccines and these codes to utilize from that source, as well as within the CPT manual. So digital medicine was another area. Oh, actually, I wanna just mention, I'll mention this kind of upfront here. So, we heard a lot about audio only. And so one of the things that is part of the CPT symposium is CMS gives an update. So CMS kind of has their own special hour that they spend updating us on initiatives and payment rates and kind of their methodology behind some of their decisions. And they did want to stress that the reimbursement for the audio only services that they're currently reimbursing for, as of now, the payment for these services is going to remain in place through the end of 2022. Or if they end the PHE early, that could change. But right now, I don't think they're looking to end the PHE that early. But they said that we should expect that the reimbursement rate will not remain in place into 2023. So that's just something to keep in mind when we're thinking about audio only and some of that work that we're doing for our patients in that area. So getting into remote therapeutic monitoring, there's some codes that they've developed, the 98975 and through 77, and there's some particular utilizations for these codes. The 75 is for that initial setup and patient education for that monitoring device. And then the 76 and 77 is for the recordings and transmissions. And whether you report 76 or 77 is dependent on if it's a respiratory device or a musculoskeletal remote therapeutic monitoring device. So that's what's going to differentiate between those two. And CPT does have guidance within that section of the CPT manual to guide you on the use of those codes. And then there's now codes for the therapeutic monitoring and treatment management services. These are time-based codes, and they're designed to report the treatment plan that the providers put together for the patient when they're using the results that they're finding from the remote therapeutic monitoring that we just mentioned in 98975 to 77. So once that treatment plan portion of it goes into play based on that information that they've gathered, that's when 98980 and 98981 would be reported for the patient. And then there's this audio only telehealth modifier, but I want to make sure that I mention that this is still under panel consideration, and it's just a one-letter modifier, which is different from what we're used to seeing with modifiers. It's a Y modifier. It's not something that needs to be utilized now. They're still considering how they want this to be used and when it will be used. And I think this is just in preparation for the future when the PHE ends and we still have audio only as part of our treatment for patients, and how CMS plans to handle the reporting and the reimbursement for audio only type services that patients are receiving. So I just wanted to give you this information on the Y modifier just as an FYI. And then there's some category 3 codes that are also within the digital medicine arena, and that's the cognitive behavioral therapy codes, and I have those listed there, as well as remote amblyopia treatment codes. And so if these are services that your organization is providing or plans to provide, these category 3 codes are going to be the area that you're going to want to go to try to report these types of services. And then the Appendix R is another appendix that's been added to the CPT manual. And what it is, it's like a digital medicine grid that lists the digital medicine services, and it classifies them into different categories based on the nature of the service being provided. So just an example I can give you is one classification could be a clinician to patient service, or it could be a monitoring service that's done via a synchronous or non-synchronous communication. So there'll be different ways to look through the columns and pick which category it falls into. So that's another good reference guide that they've included for digital medicine services that are being provided. So here's the principal care and chronic care management portion that they added some codes and they revised some descriptors and some instructional sections within CPT. So the first thing that they did is the Medicare G code that was in place for principal care management has now been converted to a category 1 code, 99424. And then the add-on code for principal care management is 99425. And these are time-based services. So you'll want to look in CPT and see what the different time periods are that have to be documented for the use of these codes. And it's not 100% consistent between each section. You know, CCM might be a little bit different than PCM. So watch those different time increments within these different sections. And these codes can be assigned by the physician or another qualified healthcare professional. And the 99426 and 427 are specifically reported by the clinical staff. And then they also added some codes in the CCM section, 99437, and that's assigned by a physician or other qualified healthcare provider. And 99439 is the clinical staff CPT code. And one of the things that CPT did within this section is they revised their instructional notes to align with the CMS criteria. So we have more consistency there, which is very helpful, I know, for all of us. So the care plan oversight instructions, the time requirements, which is a big deal to have the time requirements be consistent between the two. And then one thing to note is that CCM and PCM are mutually exclusive, so you wouldn't be billing those together. And there are some unit limits on reporting where you can't go over a certain number of units for some of these add-on codes. So I would highly encourage you to look through this section, read through those instructional notes, and note those things that your organization is performing so you can educate your staff on what the billing requirements are as well as the documentation requirements. Okay, so the laboratory and pathology section. So I'm not a lab technician, so getting into the weeds on all of the nuances with the lab test is probably not my forte, but I definitely wanted to point out that there's these antibody tests that have been developed, the quantitative antibody testing, as well as numerous codes under the antigen testing section. So a lot of these are revisions, and what they tried to do is clarify what CPT code should be reported for the different tests that are being provided in various organizations. So one thing I would stress for this section is to go through this in detail with your lab directors, your lab technicians, and understand what are the tests that are being ordered by the providers. What is the tests that are being run within the lab? Some of that may be dependent on the type of test that was purchased, where it was purchased from, the type of equipment that the lab is using, and then correlate that with the correct CPT code. And then make sure that the systems are all updated to be able to order, perform, and then charge for the correct CPT for that particular lab test. And then the PLA codes that I mentioned earlier are those proprietary codes. So if these are any testing under these categories that are being performed at your organization, you'll want to assign these specific PLA codes and ensure that those are being utilized at the organization. And I wanted to point out that the pathology clinical consultation codes 80503 to 80506, the guidelines for the use of these codes has been revised. And what they've done is they've really gone in line more with how the E&M office visits are structured. And they've got time considerations, and they actually include the medical decision-making table as part of these consultation guidelines. So there is more consistency between these pathology consultations and what we see with the office visits. So take a look at that section too. And if that's something that your pathologists are providing, we will want to make sure that they're educated on these guidelines. And then there's been some new immunology testing codes, and celiac testing was one of the big areas in this section where they really identified and detailed out some specific testing for celiac disease, and they've assigned specific CPT codes to these different types of antibody and tissue tests. So I know celiac disease is something that's becoming more and more prevalent, and so these codes should be helpful in reporting the correct type of test that's being ordered and conducted. And for the radiology section, just a couple of things here. The first thing is a new series of category 1 codes. So there's a 4-code structure for the trabecular bone score. So if this is something that's performed in your organization, you'll want to take a look at these 4 codes, and it allows for separate reporting for the various steps that the facility must go through for this type of study. So if your facility is performing the entire series, the entire service, that's going to be 1 CPT code. But then if you're performing the technical component of the transmission or the offsite analysis, then you have some different codes to report. And then that interpretation and report of the data is its own code. So that way they've divided out these pieces for this bone score based on what organizations might be doing differently, because not every organization performs the entire service. And they revised the CT of the heart CPT code 75573. And the reasoning behind this is they wanted to remove the word venous from the description and add the term vascular, because they felt that provided more clarity that the exam includes all vascular, the entire vascular evaluation that is performed, and they didn't want to specify to just venous. And I also want to point out that this code is specific to patients that have a congenital heart disease. That hasn't changed. And 75574 is still going to be the correct code to report when the coronary arteries in a bypass graft are studied in this CT scan. There are numerous category 3 codes that were added for radiology, and I didn't list every single code here. We'd have way too many slides on category 3, but I did list the names of the exams where they introduced a category 3 code. So if these are any types of radiological exams that you're performing at your organization, you'll want to look at these category 3 codes and ensure that you have those communicated and built in your systems. Okay, with that, I am going to turn it over to Susan.
Thank you so much, Rachel. I am going to be going over some of the sections in the surgical portion of your CPT book. And in order to stay on track for time, how I have arranged these is, I'll tell you the section that we're going over. The first slide will be what the changes were, the additions, the deletions, the verbiage changes. I have chosen what I believe is the most common out of those to go over. And then the last slide will be some RBU information. The first category we're going to talk about is generalized cardiology, excuse me. So overall changes, we have some 3D imaging of the cardiac structures, cardiac ablation, intercardiac echo, excuse me, I apologize, echocardiography, autonomic function testing, some category 3 codes for remote programming, and then some non-invasive arterial plaque quantifications. The codes that I chose to just, whoa, going too fast here. The codes that I chose to go over were the cardiac ablation codes, and that's going to be your 93653, 93654, and your 93656. So what happened here is that when the AMA RUC group gets together to determine how often codes are assigned, if they're assigned together, etc., this is how these codes come about to be bundled. And what they determined was a lot of the work described by code 93656, which is that comprehensive EPS evaluation, a lot of that was being billed with other codes. In fact, up to 75% of the time, that code was being assigned with other codes. Right there, that told them, okay, hit the brakes. We are going to start bundling this. As they dug a little bit deeper, they determined also that 93653, also a comprehensive EPS evaluation, but this one is with the insertion and repositioning of multiple electrodes, also was bundled into several other codes. They decided what would be easiest is if they came up with some tables that they could put in the book. It's also worth noting that your documentation for these codes, if this is an area that you work in, the documentation has to have the following. We need to see the diagnosis of why it's being performed, any signs and symptoms, history of present illness, and then results of the diagnostic testing and treatments tried and failed for the physician treatment plan. And these are the charts that I was talking about that are listed in your CPT book. As you'll note, there's 3 of them, and they tell you the CPT codes across the top. You have your 5.3, your 5.4, and your 5.6. And then along the left-hand side, they tell you a certain procedure, and if it's inherent, bundled, or not bundled, because it can sometimes be performed. Another grid. And then when we want to talk a little bit about the RBUs, so when we were getting to the EP ablation codes, they're not really revised from the proposal. They are going to maintain their existing RBUs despite being bundled. So the change in this results in significant reductions due to the shorter procedure times reported in 2 separate surveys that the RUC committee performed. So CMS says it will consider additional information from the second survey in their future rulemaking. So as you can see, the current RVU for 5.3 was 14.75. The RUC recommended 18.49. CMS said, no, we're gonna keep it at 14.75. And you can see that down the list that it either was kept the same or decreased, which never makes the specialty societies very happy. The next category we're going to talk about is interventional cardiology. I'm not sure if a lot of you out there listening perform these, but this would be your percutaneous cerebral embolic protection. We have a new code there. The endovascular repair of aortic coarctation, got 3 new codes there. And then the cardiac catheterizations for congenital defects. We have 6 new codes there and 6 deleted codes. We have several, like Rachel said, category 3 codes: transcatheter ventricular restoration device implantation, percutaneous cardiac mass removal. The surgeon that presented on this at the symposium was very excited about that. Transcatheter coronary sinus reduction device implantation, the TTVI replacement, intraarterial hyperoxemic reperfusion, and that therapeutic ultrafiltration. Today, I chose to discuss the cardiac catheterizations for congenital defects, as that is where the major changes happened. These are going to be your codes 93593 through 93598. It's going to include the catheter placement and the injection, all of the work of the imaging guidance, including that fluoroscopy and that ultrasound guidance for the catheter placement. For cardiac catheterizations for congenital heart defects, the injection procedures are separately reportable, again, due to that marked variability in the cardiovascular anatomy that's encountered. When we get into this, we're going to be talking about native connections normal and native connections abnormal. Goodness, I don't know. I apologize. Every time I click my slide forward, it goes forward 2 slides. So I apologize that we have to keep coming back. So we have the normal native connections, and that's when your blood flows along the expected course. And some examples of this for congenital heart defects would include those acyanotic defects, like your ASDs, your VSDs, or your PDAs. When you get into those abnormal native connections, that's when there's alternate connections for those pathways. You're going to get into some of those cyanotic congenital heart defects or any variation of single ventricular anatomy. Examples of right heart catheterizations through these abnormal connections would include, but not limited to, accessing the pulmonary arteries via surgical shunts, accessing the pulmonary circulation from the aorta, or accessing isolated pulmonary arteries through a PDA. We know that the normal native connections flow along the expected course through the right and the left heart chambers. Normal native connections, they exist when the pathway of blood flows the expected course through the right and the left heart chambers and the great vessels. Some examples or services including right heart catheterization for congenital cardiac anomalies with normal connections are reported with the 93593 and the 93596. Those abnormal native connections or the alternative connections for the pathway of blood flow through the heart and great vessels, those are typically found in patients that have like tetralogy of Fallot or the hypoplastic left or right heart. Those are those alternative connections. And those are going to be CPT codes 93594 through 93597. So here's a grid that I made for you guys to show you the type of connection, the definition of that type of connection, the CPT code you will use, and then any examples. So for example, if we're going to use the top one, it's a normal native connection. And again, you're going to have to speak to your providers to let them know that this needs to be in the documentation. You're going to use those codes 93593, 95, and 96. And some examples of that would be ASD, VSD, or PDA. And again, here's another grid. If you're doing a cardiac catheterization for the congenital defects, if you're doing the right heart cath, 93530 was the old code. That is now deleted. Now you're going to use 593 and 594. And it also tells you what's included. So it includes that catheter placement, including that imaging guidance, whether that's fluoroscopy or ultrasound. It includes obtaining the blood samples, and it includes the FIC cardiac output measurements. And those all have to be, of course, documented. Now we're going to get into the cardiothoracic surgery section. Again, unsure at your facility how many of these procedures you're performing, but we have the exclusion of the left atrial appendage. We have that harvest of the upper extremity artery, and that's endoscopic or open. And that is going to be the one that we're going to discuss because that is pretty common. The peroral endoscopic myotomy or the POEM. Some category 3 codes are that synchronized diaphragmatic stimulation to improve cardiac output, and then the body surface mapping. Let's talk a little bit about that harvest of the upper extremity, endoscopic and open. If you're going to report that endoscopic harvesting of a vein, which we have been doing now for several years, we're going to use that 33508. Now there's a code if you're going to harvest an artery in the upper extremity, and that's 33509. That's for one segment, and it's done endoscopic. AMA and CPT also included some verbiage telling you that if you're going to do it open, you would still use 35600. And if you're going to perform it bilaterally, you can append modifier 50 to 33509. If you are doing it open, the CPT code again is 35600. And if you're going to do that bilaterally, you can also append modifier 50 to that. When the RUC group committee was going over this code, they did determine that a majority of the time, someone separate is performing this, whether it be a mid-level, your surgical assist, etc. They're going to be performing the harvesting while another surgeon is actually doing the cabbage. So these codes can be assigned as standalone codes. They were valued like add-on codes because you would use them in conjunction with other codes, but they can be a standalone code on a claim. The Specialty Society noted that the radial artery is typically used in situations where a patient is undergoing a reoperative cabbage, where the interthoracic arteries have already been used, and the patients with limited saphenous vein conduit that are available due to prior use in peripheral vascular disease or previous cabbages. Recent studies appear to indicate that the use of radial artery grafts for cabbage may result in better postoperative outcomes than using that saphenous vein graft, which we have been used to seeing over the years. So as a result of this, the use of the radial artery in cabbage has definitely been on the rise. Originally, that radial artery was harvested using an open technique, but now with all these technological advances, it's possible now to get that radial artery using an endoscopic technique. And then that method of harvest, where available, is obviously going to be the preferred method, because anytime we can do something endoscopically as opposed to doing it open is better for the patient for their post-op care. And on this slide, you can see what the RUC recommended and what was actually approved. These are previously did not have an RBU. They were recommended at 4 and 3.75, and you can see that the final CMS work RBUs brought them down to 3.59 and 3.34. Anesthesia and pain management, they did not have a lot of changes. We have some in the image-guided spinal procedures, a couple in the destruction of interosseous basovertebral nerve procedures, and some in the epidurography. We're going to talk today about CPT codes 01935 and 01936. These were deleted. CPT 01935 used to state that it was anesthesia for percutaneous image-guided procedures on the spinal cord, diagnostic, and 01936 was for therapeutic. Those were deleted and replaced with spinal levels. So now you have 01937, that's for the cervical or the thoracic, and 01938, which is for the lumbar or the sacral. We have an example of a clinical vignette of both of these codes, and what's very important to notice on both of these vignettes is the very last sentence. You must provide a post-anesthetic report. You have to document elements of the anesthesia care, including vital signs at least every 5 minutes, positioning, anesthesia procedures, medications, and any significant events in the anesthetic record. That's very important to note. A lot of times when we are doing reviews, we will see some of the key components that are missing. It's important to speak to your anesthetic providers and make sure that they're getting all of this in their documentation. And there's the vignette for 01938, same situation as 01937. And if we look at the RUC recommended RBUs, they recommended 4.00 for both of them, and they achieved that. And I will tell you that does not happen very often. All right, the next section we're going to talk about is neurosurgery and spinal procedures. These have some new codes for intracranial laser interstitial thermal therapy, or what's known as the LIT procedure. Big changes under arthrodesis decompression. We have some destruction of interosseous the basovertebral nerve, and some category 3 codes with the anterior vertebral body tethering. What we're going to talk about today is 2 new codes that were created, 63052 and 63053. These have been established to provide reporting when you're doing a laminectomy in conjunction with a spinal fusion or an arthrodesis. This has been such a hot topic for as long as I've been coding, and like I said, that's been 20 years. Whether you can assign it, whether you can assign it, is it bundled, is it not, what documentation do you have? So the AMA came up this year with 63052 and 63053 to hopefully clear up some of that confusion. The intent of these codes is that they're only to be reported as add-on codes when a decompressive laminectomy is being performed in addition to those fusion codes. You have to utilize inner body laminectomy techniques. They should not be used in conjunction with other fusion procedures. They should not be reported if the laminectomy is to prepare the inner space for arthrodesis. And that has been a rule for as long as I can remember as well. Or if you're just trying to allow better access for completing the fusion procedure. This is definitely spoken about in the CPT book. There are guidelines in there. So you're going to want to read all of those code descriptors. You're going to also notice that the code descriptor for both of these codes only notes lumbar vertebra as the segments of the focus. No other, it does not state cervical or vertebral. The intent is that if the decompressive laminectomy is performed by itself without fusion, you're still going to use those existing laminectomy codes that are under 63040 through 63058. Also, CPT has finally put some illustrations in for some of the common procedures like a corpectomy. And they tell you the percentage that has to be met in order to assign those codes. So for a cervical corpectomy, you can see it has to be greater than 50%. Thoracic has to be greater than 33%. And lumbar has to be greater than 33% as well. We can see for the facetectomy and the foraminotomy, I am so sorry, this cold has definitely got to my head. You can see how much of the area of the bone has to be removed during the procedure as well. It's in that blue highlighted area. The hemilaminectomy, lamina, laminectomy, and laminotomy. It also gives you great descriptions now of these procedures and what needs to be done. Very important to speak to your spinal surgeons about when they document, if they can, as much as they can get in there about how much they're removing or where they're exactly located at. That's the best that they can do so you can capture all those codes. And this just has what we just spoke about. So 22600 through 22634, those are your arthrodesis codes. Those have been revised for 2022 with changes to the code descriptor and the addition of instructional guidance. The descriptor for the parent code, that 22600, was revised, and the term level was deleted and replaced with the term interspace. We also know that there's been some parentheticals added with instruction regarding the appropriate use of 22614. Descriptors for arthrodesis codes 22633 and 22634. And then we have those new laminectomy codes 63052 and 63053. Some new parentheticals were added to 63048, instructing the use of appropriate reporting for the decompression performed on the same vertebral segment and or interspace as the PLIF. And that includes the laminectomy, the removal of the facets, and the opening or widening of the foramen. Here are some of the RBU information. Since those are just newly added codes, they didn't have an RBU before. The RUC recommended quite high RBUs for these at 5.55 and 4.44. Of course, they did not get those, what they asked for. Instead, it's down to 4.25 and 3.19. Next, we're going to go into the orthopedic surgery section. A lot of what happened here wasn't necessarily with codes, but more along the lines of that introductory language. So we have restorative care, we have cast and strapping guidelines, and we have new headings for musculoskeletal tumors. We have a couple new level 3 codes and changes to level 3 codes. We have extracorporeal shockwave therapy, or that ESWT, markerless 3D kinetic motion, and injection of bone substitute into the subchondral defects. We're going to talk about some of the definitions and then the rationale for them. We have a new subheading titled Reporting Fracture and Dislocation Treatment Codes. The guidelines in this section now can provide users with a basic instruction on the reporting structure for the fracture, fraction, and dislocation treatment codes. These codes are categorized by the type of treatment, and that's whether it's closed, percutaneous, or open, and the type of stabilization, which is that fixation or that immobilization. There's no coding correlation between the type of fracture or dislocation, as like open or compound, and the type of treatment, closed, percutaneous, or open provided. For example, you can have a closed fracture and it may require open treatment. So it's very important, again, that we educate our providers to let us know what type of fracture it is and the treatment that they're performing. So we see can we go back real quick? We see manipulation has been revised to state that if satisfactory alignment is not maintained and the same provider is performing the second manipulation, we need to add that modifier 76. For closed treatment, it's been revised to clarify that casting, splinting, or strapping is used solely to temporarily stabilize the fracture for patient comfort, and it's not considered closed treatment. And then for that external fixation, that's been revised to clarify that the treatment involves the difference between uniplanar and multiplanar external fixation, and to clarify the appropriate reporting of the external fixation. Now we have some fracture and dislocation treatment definitions. It goes into great detail in the book to tell you exactly what manipulation is, what traction is, what closed treatment is, what percutaneous skeletal fixation is, and what open treatment is. And in order to save some time, I won't read those particularly, but if you have any questions, please let us know. And the next slide is just an example of some of that fracture care. This is a distal radius fracture that's minimally displaced. It tells you the patient went to the ER with this. The ER provider decided the fracture does not need a reduction and just put them in a cast or a splint. They were sent to that outside ortho office to be seen and evaluated in a week. So the ER provider will not be providing that follow-up care. And then it tells you what you can assign for that ER provider. And this last slide is talking a little bit selfishly about the category 3 code 0707T, which is an injection of a bone substitute into that subchondral bone defect. I was very interested in this as I have a child who continues to get stress fractures in her legs. And when I saw that this was going to be performed for stress injuries, I wanted to read up on it. Once I read up on it, I was sort of mortified and did not want to be proceeding with that route. I think we'll stick with the crutches and compression boots instead, because this is quite a lengthy procedure. But I did think that was kind of a cool thing that is on the horizon. And with that, I'm going to turn it over to Rachel to finish up with urology, otolaryngology, audiology, and ophthalmology before I come back and talk to you a little bit about the E&M codes.
All right, so I'm going to breeze through these next few slides quickly so that we can be sure to give Susan some time to go through our E&M information with the time that we have left. So a couple of changes in urology with some category 1 codes, and really what this section is some category 3 codes that were converted to category 1. So there isn't really a new description to go along with these codes, but these are the periurethral balloon continence device procedures. And really with With these codes, it's based on whether it's a bilateral insertion, a unilateral, or removal or adjustment. So that's what those devices and those different codes would mean. There's new instructional notes for CPT appropriate reporting, and also to note that these codes will include the cystourethoscopy and the imaging guidance that's also performed. Then they did revise some category 1 codes for the bioresorbable controlled release hormone implantation. This revision allows for more than just a non-biodegradable implant, but includes other types like bioresorbable, biodegradable, and non-biodegradable implants. And then the repair of hypospadias code section, there were just some description changes that took place based on the repair code, the different types of repair that might include a closure versus a skin flap and urethroplasty, whether it's an extensive repair, and then also the revision code. So they did revise those descriptions to better describe the differences in those procedures. And then there were some category 3 codes around these areas: uterus transplantation, dual energy tissue remodeling, ultrasound guided focal laser ablation, and periurethral balloon continence device procedures. So if you perform those in your facility, you'll want to look at those category 3 codes that they made some changes to. In otolaryngology, there are 7 new category 1 codes. One is for drug-induced sleep endoscopy. So this is really like an endoscopy under anesthesia. And the current code doesn't really describe the work that's performed by the provider for this type of endoscopy. So they wanted to revise or develop an endoscopy code that's specific for this type of endoscopy. And usually this is performed when the provider wants to evaluate a sleep disorder, a breathing sleep disorder, and they need that patient to be in a deep sleep in order to do that. They also switched some category 3 codes over to category 1 codes for the hypoglossal nerve stimulator services. And so these are those services that would be the open implantation versus a revision versus a replacement of those stimulator systems. And then also the, it looks like we just have that in there twice. So get 2 of those in there. One thing I did really want to mention with the section here is the nasal bone fracture code changes. So with these code changes, 21310 has actually been deleted. And so now when we report a closed nasal bone treatment of a fracture without manipulation, so that's without manipulation, we would report it with the appropriate E&M level. And this is very similar to how CPT has moved, trending towards how they are reporting rib fractures without manipulation, as well as like a toe fracture when we use like buddy tape or something like that. So this is just really in line with what they've done in those other areas, is removing this code. So now we report 21315 and 21320 for those fracture treatments that include the manipulation. And so they've revised these codes so that they describe exactly the differences between those 2. There's also some transcutaneous passive implant temporal bone codes that were added, and there's 4 codes here, and they're added to report the implantation of the osseointegrated implant into the skull. So there's the implant code. There are a couple of revision codes depending on the extensiveness of the revision, and then there's also 2 removal codes, the 26 and 27 there, dependent on how that was removed. So you'll want to look at those descriptions. And then also within this category 4, there was 2 codes that were already in place, the 69714 and 69717. And they really just revised the descriptions of these codes and included new introductory guidelines to reflect the current practice in the performing of these procedures. In audiology, there were a couple of testing codes that basically were deleted and replaced with the auditory evoked potential testing codes, which were already in place as of last year. So 92650 to 92653 are already in our CPT book, and they've removed these other codes because they're just really not reflective of what is being performed in the audiology practice these days. So the AEP codes have really taken over this section. They've also revised some other AEP codes that have been within this section, and there's new parenthetical notes that were revised because of questions that they were receiving on how to report these codes correctly. So per CPT, a moderate to high level stimulus is used to evaluate the AEP response in all of these codes. Therefore, we wouldn't report 92651 and 92652 in conjunction with 92653, since that would be inappropriate. And they go through some scenarios within CPT to help you guide you through the use of those codes. And there's also some evaluation of auditory function codes that have been revised. And again, it's just to give more clarity into the intended use of those CPT codes so that we can assign those codes appropriately. And then ophthalmology, really there's a lot of category 3 that's really been turned more into category 1. So the cataract removal with a drainage device insertion was moved from a category 3 to category 1. They did still keep or actually add a category 3 code within this. So it's kind of a 3 code combination, 2 being a category 1 and 1 being a category 3, which is kind of different. For the lacrimal drug-eluting implant, this code was category 3 code was switched into a category 1 code to separately report the supply of the implant. And then also the so the 99070 separately reports the supply, and then the 66841 can be reported for each eye. There's a new code. It's a point of care analysis and report code. So if this is something that's performed within your department in ophthalmology, you definitely want to take a look at this section and see what is it that's being done and being performed, and how do we report those correctly. They did make a few code revisions with dilation of aqueous outflow canal and retinal detachment prophylaxis. There's also some category 3 revisions that I've listed here. And I want to get it back over to Susan so she has time to go through some E&M information for us before our time is up.
Thank you so much, Rachel. And I could honestly speak about the evaluation and management codes all day long, but we only have a few minutes, so I will try to be as swift as possible. As we know, the new code groups became effective January 1st, 2021 for dates of service, January 1st, 2021. It was the patients over paper. Oh, can we go back? It was a patients over paperwork initiative. They wanted to really reduce the amount of documentation that providers had to do. So the goal of the revisions was to better reflect and incentivize activities that make patients better, while making reporting and documentation of the visit less burdensome to the provider. After they came out, it was clear that there was still areas causing confusion. And if you've listened to me present on the E&M code updates, you will hear me say under the medical decision-making grid that bucket number 2 is very, very confusing, and that I thought they would put out an errata. They actually did put out an errata, or the technical corrections. They put that out in March, the CPT panel did. Some of the questions that were asked of the panel and why they wanted to come up with these technical corrections were, hey, how can we document XYZ? The panel was starting to see samples of documentation, and they were very disappointed that some of the samples were overly detailed time documentation templates, for example. What we're seeing out in the field is that a majority of facilities are still using 1995 and 1997 guideline templates. So it's still auto-populating all of that information that is no longer necessary, and kind of negating the purpose of these E&M code revisions. Some of the questions that were exposed were, we need a consistent interpretation. That's still a goal. And the guidelines need to be clinically relevant and practical. So for example, changes related to reporting tests came about as multi-specialty or health system practices were trying to understand the difference between ordering and performing a results-only test. Some of the updated guidance. When can a test actually be counted as ordered? So the previous guidance was, If a test can be reported under an existing CPT code and is reported by any physician or qualified healthcare provider of the same specialty or group, it was not counted in that bucket 2 in your medical decision making. We went over that. We stated EKGs were probably the most common thing that was going to be ordered and performed by the same provider. That provider would assign a CPT code for the EKG. It would not be able to be counted. Now, the current guidance states if a test does not require a separate interpretation, so if it's a results-only test and is analyzed as part of the medical decision making, you can count that as one bullet towards your ordered and review in that second bucket in medical decision making. How about reporting of tests, the independent interpretation versus the ordered and reviewed? The question came in, based on the E&M office visit guidelines, when a physician in the group practice orders and performs a diagnostic x-ray, is it appropriate to count ordering of each unique test, but not review of the results, because they're going to be reviewing those results? The answer is, if the test, in this case, the x-ray, is separately reported by the physician who's also going to assign that E&M service, then that test may not be used in that second bucket under medical decision making. A chest x-ray requires an interpretation, therefore it is not a results only study. So are we able to get around the same specialty? And the answer was a resounding no. That concept is in place, so you are not double dipping. You cannot count time towards the E&M level that was already reported by a physician or another QHP or a member of the same group and specialty for that reported test or procedure. They want to stay away from getting credit for one item in two separate ways. And then the time, it was re-emphasized for those standard interpretation. Do not count time spent on the following: any services that you're separately reporting a CPT code for. Do not count time that you spend traveling, and do not count time that teaching that is general and not limited to discussion that is required for the management of that specific patient. Cannot be counted. Okay. Go ahead, Rachel.
Okay. All right. So I do want to mention social determinants of health. This has been something that we've been hearing a lot about lately, just everywhere within healthcare and outside of healthcare. So the definition of social determinants of health is the environmental conditions where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life risks and outcomes. And one of the things that the presenter shared with us during the symposium is that clinical care and health behaviors account for 50% of the factors that determine an individual's health outcomes. That other 50% is determined by these social determinants of health. So what has happened with the E&M office visit coding is now we have social determinants of health as part of that medical decision-making portion of the E&M visit. So we know that total time in medical decision-making can determine the E&M service level. So that care coordination piece, that does incorporate this social determinants of health piece, and it recognizes the importance of those non-face-to-face activities for these patients. And that prolonged service CPT code that's been in place also provides an opportunity to capture the extended time that's used for the level of code selection. With the medical decision-making table, now the table of risk includes the diagnosis or treatment that is significantly limited by social determinants of health, and it's under that risk of complications column of the table. So when this information is documented by the provider in that E&M visit note, this is information that can be incorporated into that medical decision-making, or if it's a time-based E&M service or decision based on time, that should also be documented in the medical record. So I did go ahead and include examples of what this, like a case study. So this is just for your information to take back and read through this, a couple of case studies here on what we would be seeing in the medical record that speaks to the social determinants of health for that patient and how that impacts the ability for the provider to treat and care for that patient, or what might limit them in the care for that patient. So this is an emergency department case study. And then on the next slide is a clinic visit case study, and how that could be, how the social determinants of health for that patient would be impacted. So I'll just leave you with these to read through, and that way you can take a look at how that might be impacting the level that's chosen by the provider or the coders if they're doing the coding, and what documentation you would typically see. And then on that last slide, just wanted to remind everyone to review these CPT code changes in their entirety in more detail, since we did kind of a rapid fire lightning review of the CPT code changes for this year. Schedule those meetings with your clinical departments that are affected by these changes and go through those, inform them, determine if there's new exams and tests or procedures that are going to be performed, and then make sure you update the charge master, your preference list, your order entry systems. Make sure there's a charging mechanism in place to accommodate for all of these code changes. All right, I know we don't really have a lot of time left for questions, but if there's anything, feel free to reach out to Susan or I for clarification or any additional information that we might be able to help you with. And thank you so much for being here and listening with us today.